Hello, everyone. Good morning. I hope everyone's awake. Thank you so much for the invitation to come in today. And so I thought, because we're at a laser conference, let's give the spotlight to peels. Why not? And I wanted to give it a different approach, more in terms of business. So imagine that you're starting your practice. It's a startup, right? So you want to increase productivity, you want to increase revenue, you want to decrease costs. So what would you do? You would choose a peel over a laser. So this first case, this lovely lady came in and she wanted textural improvement to her skin. She was open to getting neurotoxin as well. So I treated her with a medium depth peel, but it was actually, since it's not CME, I treated her with a VI advanced peel, which is comprised of salicylic acid, TCA, phenol. We did inject neurotoxin to her upper face, glabella frontalis, her orbicularis. She did get a subtle lip augmentation. And so she actually got a wonderful result just from those things, something similar to what a laser would give. And so when you're thinking about costs in terms of how much that peel cost you, it's around $60 to $70. You can charge the patient, depending on the area, between $300 to $500. So your investment gain in this particular case is around $430, and your ROI is upwards of like 600%. So when you're starting out and you can't necessarily purchase a 100K, 200K laser, a peel is a great add-on procedure, and you can actually get great results from it. And that's my first case, in case there's any questions.
So I will say one thing. I believe this is a CME session, so we will try to refrain from too many product names. And if you got questions at the end, we'll be more specific at that time. Do you feel comfortable doing medium depth chemical peels and neurotoxins on the same day, and how do you time them, especially given how much swelling some patients can get, like Dr. Watchmaker's case? Do you have concern for risk of any spread?
So we'll usually apply the chemical peel first, and then we'll administer the neurotoxin. With this particular peel, I haven't had as many edema cases, so it's not something of concern to me, and this is something I do almost every single day, and I haven't had any toxin spread as of yet.
And Anthony, I know you use, again, different kind of peels, but can you comment on sort of the economics as well?
Yeah, I mean, I agree with Nolani, like the cost is amazing to you, and then, the investment gain is great. I use a different brand that's just like basic peels, like I'm sure you all use them too. And they're just like the individual, like sal acid, TCA, Jesner, modified Jesner, and the cost is, to you, is like very low.
Yeah, so if you buy a bottle of one of those other ones that's not one of these fancy kits, your cost might be,
It's like $40 a bottle.
Yeah, which is like pennies on the peel. So, it doesn't come as like a fancy kit, but you can make that kit yourself and like brand it your own brand, sort of. So I mean, it's something to think about as like an investment. Yeah.
Mm-hmm.
If do any of you have a laser or device, like a patient wants a same-day treatment, something that you do where they don't need to numb for an hour or something before the procedure that you have in your office? I guess you got to be kind of careful in terms of the brands, but like I've got a 1064 nanometer ND-YAG that's a millisecond wavelength, and you can just kind of gently pass over the skin to heat it up. And there's no downtime with the procedure. They don't need to numb. Or sometimes I will do a low density 1927 nanometer thulium treatment, and I won't numb them for it. If I'm doing a very light treatment, I'll just kind of go over a few passes. Anything else that you like to do for like that laser patient who wants same-day treatment?
Yeah, I do think like the peel is just such a great add-on because A, they get results. B, there's some downtime, but the downtime is not so much where they have to interrupt too much, and they can push through it. So they get the balance of like, they know it's working, there's efficacy, they can see it, and they get results, but it's not interrupting with their life. That microsecond 1064 ND-YAG is nice. It gives a little glow to the skin, but it's not as, I don't think it's as effective as like a medium depth peel.
And I
by
know if
far.
a patient comes in and they've got some brown spots on things, if we're just doing like a picosecond treatment focally, then when they're healing and recovering, they've got all these spots sort of all over the backs of their hands and their face. At least with the peel, it's a little more uniform.
Yeah.
And so sometimes that's a little better tolerated, that downtime. And they like that physical aspect of that peel. And like Dr. Watchmaker said, it can almost be a good selling point if you're doing these to the others in your office when they see that nice glow to the skin after you do the peel.
They do. You'd think they don't want to peel, but then they're excited, or they'll complain if they're not peeling. So they do like that peeling aspect.
Yeah.
And I think another great add-on, which doesn't have a lot of downtime, is something like a Jesner's peel or even a sal acid peel for same-day office treatments, and they'll get that glow. It takes nothing to do, like 5 minutes to do, and patients are usually really happy after that.
I love Jesner peels.
Yeah.
I do think that's a good point, though, because like glycolic peels, like sal acid or Jesner's, people don't always get peeling, and I feel like if they don't get peeling and they're expecting peeling, they'll be disappointed. So I always tell them for like glycolic peels, you're not going to get peeling.
Yes, it's really important to just let them know that beforehand. I'll ask about any history of cold sores, and if they do have any history, then I will. I mean, and specifically in this patient, I was also doing lip filler, so yes, I asked. But if they don't have any history, I don't give them any.
You dispense it from your office if you need to make that quick decision?
Yes.
I do, I mean, she has a good uniform, even skin before, but if there are like really distinct lentigos, like you were talking about, Brian, sometimes I will use like a Q-switch laser and just hit them and then go over with the peel. Yeah, same.
Do you ever go over the lenticos just with the peel with like a Q-tip extra too?
I do, but I don't think it works as fast as a laser in that regard. But I could be wrong.
Okay, case 2. So this patient came in after she had an accident in a golf cart. The golf cart actually toppled and she fell, got this type of burn. And again, so if you're starting your own practice and you don't have any lasers, what are you to do? So I chose to do a glycolic acid 35% peel, and I combined that with intralesional Canalog, 10 milligrams per cc. She actually had 6 peeling sessions, and she got a wonderful result. Of course, this is 2 years after it, but granted that I didn't have a laser to help her with, this was a great result just with peels and intralesional Canalog. This was using glycolic acid, like I said, 35%, and this you can get from other manufacturers. Your cost is nothing. It costs $43 for a 1 ounce bottle. If you use 2 to 4 cc's per peel, that's like $3 to $6 per peel that you're administering to the patient. So your investment gain is between $150 to $300, and your ROI is just skyrocketing, and it takes less than 10 minutes to do.
So I have a question. I think it's fantastic. But you know, when the patient comes to you the first time, could you have predicted that it'll get there? So it's hard to promise them without knowing where you're gonna go. And this looks great, but it's really hard. If I saw this patient the first time, I'm like, I don't know if I can get you there. Mm-hmm. And I think that's part of the challenge, that I don't want to sell something that I can't promise them that I'm gonna take them there. But I just struggle with that.
Yeah, no, I agree. I think I don't look at it as though I'm selling something to them. I tend to be very honest with my patients, and so when they come in, this is a scar, right? We can never get them to what it was before, so that's something that's really important to tell them. But I do let them know I do think I can help you. It'll get better with time. I just don't know how much better. But I can guarantee that it'll get better. And they do know that it's a journey, and that it'll just never be the way it technically was before. And I think if you're forthcoming with that and you're upfront with that, then the patient tends to be happy. So try to under-promise and then over-deliver.
So I think,
Nolani, what is like your endpoint? This is great. Like, what's the endpoint that you look for with the glycolic? Or do you just do like 2 passes and then go?
So in her, I did 3 passes and I stopped.
Okay.
That first time, just to see how she would react.
and at what point did you start the treatments? Like how long after the injury?
About a month.
Because I think, if we're doing point counterpoint, one argument for the laser is I personally wouldn't feel comfortable doing a peel on something that's still healing like that, but I would feel comfortable doing an vascular laser and trying to reduce that redness pretty early on. And with like topical steroids or something still while there's that acute inflammation and try to calm that down. So I think that would be one role for perhaps intervening with a laser device a little earlier on. And then I'm curious, I see this was just a recent photo here, but does anyone on the panel feel like the peels will continue to improve upon that hypopigmentation that's there, and to what degree versus introducing sort of like a fractional ablative or non-ablative laser and like topical bimatoprost or something to try to bring some pigment back?
I think that's a great idea. I think at this point, a fractional laser and topical bimatoprost is definitely the way to go.
After the peel, did you have them apply like silicone sheets? Like, what's the aftercare for that? Because it's so good. It's such a good result.
I actually did not. The only thing she was applying was Vaseline. And I think maybe 6 months in, she did start to apply a Pracasil silicone sunscreen combination.
It's great.
Yeah, it's beautiful. I don't do a lot of peels like this, so I probably would have just done my vascular laser and started a monthly non-ablative fractional laser for this if we were doing the laser point. But again, when you look at sort of the economics of it too, for that cost of that, just the glycolic acid, that's beautiful.
Is the bimatoprost that you're referring to just at the time of the non-ablative laser servicing, or something that the patient's applying at home?
I keep it in my office and I put it on right when I do the treatment, but I do send it to their pharmacy and I have them put it on twice a day for the next 2 weeks while the skin's healing. It's up to them if they want to pay for that, if they can't get it, what it is through with their insurance. So I at least keep it in the office so I can apply some on right away.
If you apply a product like that, or have a patient use that, would you also consider using PRP on the skin after laser resurfacing?
I think you could. I mean, maybe it will help expedite the wound healing. I don't routinely do that just because of the added cost and consumable, and I'm not. I've had nice results without it, but for some patients, I do offer that as sort of an add-on if they are concerned about how long it will take to heal.
Bimatoprost, do you use the one for the aesthetic indication or the optical?
I think it's the same. Not the same.
I've prescribed both. It's the same.
Same product.
Yeah, same product.
Differently.
Yeah, the volume is different. And we know the one for eyelash regrowth, it won't be covered by insurance. Yeah, so.
What's the largest volume of bimatoprost that you can prescribe?
I think 5 mLs.
I think it's 5 mLs, yeah.
So that's not going to go very far here.
You don't need a lot.
Yeah,
It's like super liquidy and like you're just trying to get it into the channels. I mean, this is a large scar, so usually like we're just trying to repigment like smaller, but yeah. And they could, like if they get the one for eyelashes, it comes with a little paintbrush, so they could just like paint it on.
So I would have them just try to keep it confined to the areas that are hypopigmented, and as best they can because it has the little paintbrush with it.
Sometimes for fine scars, I have them buy even finer paintbrushes because I have had a few patients get it around the hypopigmented scar, and it definitely can cause hyperpigmentation.
Yeah.
It usually resolves though.
The hyperpigmentation is easier to treat though. Yeah.
Right. The channel is closed within 48 hours or something, but you have them use it for 2 weeks.
Yeah.
I still do, and yeah, I know the studies show that the channels close pretty early. I don't think we have, even the data just on showing the efficacy of bimatoprost is pretty limited, but I don't know, I feel like the skin barrier is still probably kind of compromised as you get that peeling and regeneration, and so I believe it will get a little bit more.
And you see it when people use it for eyelash regrowth, they get this like hyperpigmented streak sometimes on their upper eyelid, which is interesting. And then I tell them to stop. They've gone too far.
The BID times 2 weeks.
Yeah.
That's what I do. I don't have like a good study for that.
The cost? Oh, I think it's like 1%, is it?
Bimatoprost.
We can
take
look
a
it
look.
up.
There's just
It might be
0.05.
0.03 or something.
Yeah, I think it's like
We can look it up, yeah.
Okay.
All right, let's
Yep.
do the next one. Thank you.
All right. And so case 3 is melasma, hyperpigmentation, or photo damage. But particularly with melasma, I tend to favor peels more than lasers just because we also know that melasma can get aggravated from heat. So I tend to favor peels in these conditions, and you can still get great results by just using either a medium depth peel or many subsequent like superficial peels such as sal acid, glycolic acid, or Gessner's to get results like this.
Yeah, I think melasma is a hot topic. I know Dr. Rossi's got some cases on this as well. My typical approach is I start with topicals, and I'll do that for about 3 or 4 months, because once they start doing, I mean, you can always start doing the peels. I think it's safe, but the cost starts to add up for the patient. So I will typically do something like a topical antioxidant and a tinted sunscreen in the morning, and then I'll use a something like Triluma in the evening, or some sort of a bleaching cream, and have them do that every day for 3 months, and then I bring them back. And if it's still being pretty stubborn, at that point I'll opt for either a light peel, or some patients I'll do a very light 1927 nanometer thulium laser. We used to have a device where we would also combine it with topical tranexamic acid, and that I felt like that also worked pretty nicely as well. Just curious, peel versus laser, do you have a preference what you opt for to start with?
I start with brightening cream and antioxidant and tinted sunscreen. I do like a 8% compounded hydroquinone with like kojic acid, niacinamide, and tretinoin, and a topical steroid. And then I do like glycolic peels. I usually just start with like 30% glycolic, work them up to 70%. And again, especially the 30 and 50% glycolic, you don't get too much peeling from. And usually I recommend like a series of at least 3. That's usually what I start with. And then sometimes I'll reach for a light 1927 if needed.
And do you do the peels how far spaced apart?
Usually about a month. Mm-hmm. I'm curious, Nalini, what's your favorite peel for these melasma patients? Like, do you do just plain glycolic? What do you do?
So, I mean, it depends on the patient, but usually I'll do glycolic or I'll do sal acid, and I'll do them every like 2 weeks.
And how do you pick between glycolic or sal acid?
So if it's a skin type like 4 through 6 where I want to be careful with PIH or hyperpigmentation, then I'll tend to go with a lighter peel and then just bring them every 2 weeks. So I'll favor sal acid. Okay. Whereas someone where I think they're not gonna hyperpigment, then I might go for the glycolic acid and be able to increase that percentage. But I really do like medium depth peels as well for those patients that want to get a quick result. I do start them on a full regimen, so I actually tell them what to use in the AM and PM. I'm in Puerto Rico, and so I see a lot of melasma, I see a lot of PIH. I think a tinted sunscreen with iron oxide is so important, but they're also on a vitamin C, they're on topical tranexamic acid, and then at night they're on a hydroquinone 8% combo, like you just said, Dr. Watchmaker. And then moisturizers, just because they're not going to be able to tolerate all these things if we don't improve their or restore their skincare barrier. And then I do have them come in either monthly or every 4 to 6 weeks if it's a medium depth peel. If it's a sal acid, then every 2 weeks.
And I know there's 2 different schools of thought on either starting with a peel and then doing your hydroquinone, or like doing hydroquinone and then using a peel during your hydroquinone holiday. What do you tend to prefer?
I'll start with topicals, and then I'll either have them come back at the 2-week mark or at the 4-week mark for peels, just because I do want to prep that skin, and I mostly see skin types 4 or 5. So I just want to be careful with that possible PIH.
Is it easy to find iron oxide peels?
Oh no, that would be for the sunscreen, so tinted sunscreens.
Yeah.
Yes.
Any tinted sunscreen will have an iron oxide in it. That's what gives like the tint. So the only way to really block visible light is to have more of an iron oxide in that.
It's listed under the inactive ingredients.
It's an inactive. It's not an active ingredient.
But if it's tinted, it's iron oxide.
Yeah. It's,
Not been able to get anyone on 8% hydroquinone, like patients just turning bright red.
yeah. I think you have to suppress it with a steroid as well. I feel the same way. Like some of these combination creams, like they'll especially if it's a fluorinated steroid, like a Fluzane, like some of them will come in bright red, like an irritant contact dermatitis.
I talk with when I first started, I talked to the compounding pharmacist, and they compounded in this like special, it's called like W6 base. That's actually like very moisturizing. I use it for my tretinoin too sometimes. I still do tell patients to like start once or twice a week and slowly work up to nightly. And sometimes I will have to decrease my percentage from 8 to 6 or 4. But most of my patients with the base and the steroid can tolerate it.
The skin medicinals one, and I can't get them to use it.
Yeah.
If I can say that, that's what I use as well. And my patients actually tolerate it pretty well. There are some that do get red. I think the trick is in not prescribing anything else that can be irritating or making sure that what they're using is just gonna hydrate their skin. And sometimes patients use things that you don't know they're using, like they love skin cycling or they wanna use a glycolic acid on top of everything. So just making sure that you sit down with them and have that conversation. And so that's why I actually give them their regimen. Like I'll write down everything that they're supposed to be using, just concentrate on things that have glycerin, ceramides, so that you're just hydrating the skin. I only have them use it at night, so I won't do twice a day, and there are some patients that can only do it every other night, but they tend to tolerate it really well.
Yeah, with melasma, I think less is more. I think we need to like pare it down, especially if they're getting the peels. But I agree with Nolani. I would use peels over lasers from the jump, and then, but the topicals at home, they have to like pare down because some of them are just inflaming their skin, and they're creating so much inflammation that I think it's exacerbating the situation.
Two-part question for the panelists. Do you start with 4 and then go to 8, or do you start off with 8? And are you doing BID or just QHS?
I usually start with 8, and I ask them, like, do you have a history of sensitive skin? And then I'll start with 4, and I just do QHS. And again, I do tell them, like, use a tiny amount, start once or twice a week, and increase as tolerated.
I usually start with 4.
I only use Triluma and only at night, once a day.
Yeah.
And that's because of the tretinoin. But like if I was using plain 4% hydroquinone, do you do it BID or Q? I just learned at this conference that it's photosensitizing, so I'm like having second thoughts because Obashi, we use that all the time and we do BID.
Yeah.
Now I'm like, should I be doing QHS? And
I don't think patients can handle as much BID. Like, so I usually start once a night, you know, if they can even handle it at night.
Yeah, I would try to err on the side of doing something that's going to be less irritating, potentially, and then they can always bump it up if they're not seeing the desired result. But I think once a night, and then
Even-
use some other ingredients in the morning.
Even the vitamin C, like sometimes I think it's too irritating. And so like a lot of them are using like vitamin C and E, this combination product over the counter, you know, and it gets very irritating for them.
I also,
Dispense Triluma from your office.
No, I just send a prescription. Yeah. There are other compounded ones that you can do that, but my office doesn't do that yet.
I typically start at 8, but I think it's important to also tailor it to your patient. So when you're in that first initial encounter with your patient, I kind of tend to gauge, like, is this a patient that's going to tolerate an 8? Is she going to tolerate a little bit of irritation, or is it a patient that is going to get upset if she gets a little bit red? So if she's that type of patient, then I'll go with a 4%. But most of my patients just really want to get rid of their melasma, so I will start them with an 8, and then if I have to tone it down, then I'll decrease to a 6 or a 4, and only QHS. I won't do BID unless it's a patient that's not responding, and then I'll try to bump it up to BID or consider something like oral tranexamic acid.
Does anyone use low-dose isotretinoin for melasma? Low-dose isotretinoin? I know there's like a clinical trial going on, but
I haven't used it.
yeah.
One last question, real quick for the panel. If this was a patient with hyperpigmentation and acne scars, would you choose laser or peel?
Laser.
Is it hyperpigmentation or melasma?
No, not
Right.
melasma. Not melasma. Not melasma.
If it's just hyperpigmentation, then I would probably, and acne scars, I'd probably do a laser.
If you have that 200K laser
Okay,
that you
all
can
right.
use in your
Yeah.
practice, then I would use a laser. But if not, you can get away with using a peel.
Totally.
Finish up in a-
And that's it. No,
Okay.
peels are effective, they're versatile, cost effective. So thank you.
Yeah.